Okay, well, it is with great pleasure that I would like to introduce all of you to our colleagues from the Arkansas Behavioral Health Integration Network. Kim Schuler is an LCSW, the co-founder and CEO for this network. She provides clinical and operational expertise to primary care clinics and health systems in Arkansas through integrated behavioral health models. She has experience working in both private and public behavioral health settings in a variety of roles, from direct practice to program development and oversight. And she is a passionate advocate for behavioral health and specializes serving multicultural and underserved populations. Certainly important in the current day. Patty Gibson is a physician who is board certified. She's an overachiever, just saying, in psychiatry, addiction medicine, and anesthesia. She is the co-founder and chief medical officer for ABHIN and is a consulting psychiatrist for an Arkansas hospital system primary care BHI team, and is also serving as core faculty for community residency program in Little Rock, Arkansas, where she lives. She is the co-chair of the Collaborative Family Healthcare Association Psychiatry Special Interest Group and is an advisor for the Interprofessional Primary Care Institute. She's been actively involved in integrated behavioral health for more than 10 years, including working with blended integrated health systems in Little Rock and in Oceanside, California. And finally, Adam Whitlock is the manager of primary care for Arkansas Blue Cross and Blue Shield and serves as the leader of a multi-organization and multi-payer primary care stakeholder group that supports the practices across the state of Arkansas, where they have been engaged in this work for many years. Adam is responsible for the day-to-day management of the primary care programs and has worked closely with practices and providers in the state's patient-centered medical home program and the CPC Plus initiatives, and now Primary Care First. So with that, I'm going to hand over, mute myself, and look forward to the upcoming presentation.
Well, thank you so much, Ms. Watkins, for that introduction. And we appreciate the opportunity to be here. We'd also like to thank our Blue Cross partners for inviting us to participate in this presentation with them. So I'm Kim Schuler, and it gives me great pleasure to talk to you a little bit today about the Arkansas Behavioral Health Integration Network, or as we'll call it in this presentation, ABHIN. We're going to quickly go over some disclosures. I currently, besides being the CEO for ABHIN, have a private practice. I also do behavioral health integration, clinical supervision and coaching, and participate in the CPC Plus behavioral health work group as a co-chair. So as we start to talk to you a little bit about this work, one of the things that we wanted to do was share a little bit about who we are. We know that in behavioral health, a lot of times it's the relationship. You'll hear us talking about the importance of establishing rapport with the patient in the primary care setting. And so we decided to take a moment and just share a snapshot of some of the relationships in our lives that are important to us. I want to point out on the bottom right corner, there's a picture of Dr. Gibson and I, and this is where we meet for our when we did meet in person, this is where we would meet for our quarterly stakeholder multi-payer or multi-group stakeholder meeting. We would meet at the Arkansas Hospital Association, and here we are at our first meeting. So I had to include that.
I'm Patty Gibson, and as Kim said, co-founder with her of ABHIN and the chief medical officer. I'm also paid by the Baptist Arkansas system to be a psychiatric consultant to their behavioral health integration team that's in some of their primary care practices, and also core faculty of a newly forming residency program that's a partnership between the medical school and Baptist Health, and really looking to integrate behavioral health in these residency programs. I also serve on the medical advisory committee for Qual Choice Centene. And these are really the relationships that are super important to me. And you can see that my dog is front and center and he's on the back. But this says a lot about, my son and his wife, my husband were huge Saints fans, and that is Greer's Ferry Lake behind my best friends and I, where our headquarters is. And the picture in the bottom right is my behavioral health integration team with the Baptist system. And there's a combination of LPCs, CSWs, LMSWs, and mental health RN. And I think building a team and the relationships between the team really help improve the effectiveness of what we all do every day.
Absolutely. Relationships are so important. So now we're going to tell you a little bit about what is ABHIN. ABHIN is a technical assistance center. And then the next question is, well, what do we do? We provide support and training to primary care practices. We also facilitate change. We build capacity of both organizations and individuals, and we provide statewide, local, and virtual trainings throughout Arkansas. Our preference is in-person training. However, we have adapted, as everyone else has this past year, and we've provided all of our resources virtually through Zoom. So today on the agenda, we're going to talk about our story, the lessons that we're learning, and our future. We have this quadruple aim slide up because we want to talk a little bit about, this is really the foundation for what we're doing. It was a premise of how we started, how we formed, and really the quadruple aim is driving us as we're looking at development and our projects. So, as we've just said, ABHIN is an independent local organization. One of the unique things about our organization is Dr. Gibson and I both have worked for extended periods of time in behavioral health integration in direct practice, and have a lot of experience working in primary care practices and walking with them on the journey of how do we implement behavioral health integration, and also addressing some of the frustrations that can come along the way without appropriate training. One of the things that I feel is really unique about us and our organization is the stakeholder support. We're fortunate in Arkansas to have a cohesive team, and everyone along the way has talked to us about what are specific needs for behavioral health integration across the primary care continuum, and really helped us in developing that process. The other important piece of that is primary care practices. We have amazing engaged primary care practices who really attend trainings. They are very vocal about what are some of the needs. They ask lots of questions and really help guide us in our development of what are some of the specific areas that we need to be addressing. So as we said, we are fortunate in Arkansas to have amazing people on our team. I wanted to tell you a little bit about how we've started. So we started as a CPC plus stakeholder group, and we started meeting about 2.5 years ago. And we're so fortunate to be invited to attend this multi-payer stakeholder meeting. And I live in the northwest part of the state. So for me, it's about a 3-hour distance. And I thought to myself, this is really exciting. It's something great and that's happening in our state. I'm really passionate, but wow, that's quite a distance. And I started to realize and think about what can really happen, and will I be able to contribute any valuable information? And so after I went to the first meeting, I realized we are doing amazing work in Arkansas, and primary care practices are really changing the way they provide care. And we're looking at care from a whole perspective. And I was intrigued from the beginning and realized, yes, this is such a critical meeting, it's even worth a 3-hour commute. So we have this slide about how we love meetings, because I think what happens is a lot of times we go to meetings with a good intention. We all have something to share and we all have good information, but I don't know about you, a lot of times I leave meetings thinking about, okay, what did I take away from that meeting and what are the next steps? Well, we're proud to say that when we met as a stakeholder meeting, we really came up with an important outcome, which is the Arkansas Behavioral Health Integration Network. So we started as just this volunteer behavioral health work group because we identified there's unmet behavioral health needs in primary care practices. And we then decided, wow, there's a huge need. And it's not going to just be an hour of a monthly meeting where we're going to go ahead and resolve and solve some of these issues that have been puzzling the healthcare system for years and years. So we developed our nonprofit. And here's a little bit of a timeline to illustrate. You could see in 2018, that's when our CPC stakeholder group formed. However, for several years prior to, there was a lot of early research on behavioral health integration and the importance of behavioral health integration. I personally worked in community health the earlier part of my career and really spent a lot of time realizing, we're having a lot of access issues. We can't get people in for 2, 3, 4 months for the care that they need. And this was a specialty behavioral health setting in community mental health. We noticed there's a really high no-show rate. We could say, sometimes 40 to 50% of the time, we were having no-shows in specialty settings. We know that there was high stigma, that people were telling us one of the barriers to receiving behavioral health was the stigma issues. And so I had the opportunity to meet Dennis Freeman with Cherokee Health Systems. He is one of the pioneers of behavioral health integration, has done a lot of work in this area. And he came to the community mental health center that I was working in, and he talked about this great new model, PCBH. And I was intrigued from the beginning and thought, wow, this is really a way that we could provide more behavioral health services on a larger scale to people struggling with behavioral health needs. And maybe we could identify them and provide short bursts of care without a long-term model. So I became really interested at that point. And in 2009, I started working in an FQHC and had the opportunity to develop and implement and operationalize a integrated behavioral health program, and then became all along, I was doing direct practice. So I was growing the program and providing the direct services, but really learned firsthand the importance of this work. And Dr. Gibson, she had the opportunity in 2009, she started working on this PCMH model at the VA. And she was an integral part of starting this program at the VA in Little Rock. And since that point, we've both been working in the behavioral health integration arena. It's been a passion of both of ours, but we didn't connect until 2018. And then you saw really early 2020, we became a nonprofit. And at that point, we really started to have the ability to make this more of our life work. And you could see in the present, we're providing CPC Plus trainings to primary care practices throughout Arkansas, and not just primary care practices, but any individual and or organization that is interested in our resources. They're available statewide. On our journey, we have come across many wonderful, influential people. We had an opportunity to attend a conference in Idaho, and it was the IIBHN conference. And as we were listening to them and listening to the work they were doing in Idaho, we thought, wow, if Idaho can do it, can't we do it in Arkansas? And they've provided us with support and encouragement. They've reached out and helped us with writing a grant and really getting us started. We've also attended, and one of the things that's been a great resource for us is the CFHA conference. They provide trainings every year, ongoing trainings. Dr. Gibson serves on a work group, chairs a work group. And so we have a lot of contact with people who are talking about behavioral health integration on a national level. Our goal is to think globally, but bring this locally. So our practices are getting the information that's happening nationally, and we can talk about what are the possibilities in Arkansas. And so we're using this as ways to mentor and brainstorm and bring home resources locally. This slide is from our initial planning meeting. We're proud of that because at that point we were thinking about a puzzle piece. And at this point, the pieces of the puzzle were really fragmented, but we really realized this is important. Piecing it all together. This has been a journey for us. One of the things that we know is we have the stakeholders piece on the bottom, but I really wanted to highlight that our stakeholders have been a key piece of what we do and how we do how we perform the services that we do. I've got to say, in the early beginning, I remember talking, to Adam, Alicia, and Missy several times in our work groups and sitting down saying, we've identified these behavioral health needs. Would you like to co-lead this work group? I don't know. I don't know what kind of time commitment that will be like. I don't know how I can contribute to this. And they continued to encourage us, especially along the process as we started to talk about, we have these great ideas. We're thinking about becoming a technical assistance center. Is there a need for this in Arkansas? We have payer representation on our board. We have patient and clinic representation on our board. And so that's really a driving factor for us as we're looking at what kinds of programming and training are we going to be providing throughout the state. Our vision is better health for all through integrated solutions. And we truly believe that. We have been working on building relationships and acting as a bridge to provide best practices and resources through education and training to all the participants that we serve. Here's some of our core objectives and activities. As I said earlier, we're a technical assistance center and we do provide training opportunities. One of the things that we're doing, and we'll talk more about this later in our presentation, but we're trying to develop local expertise and equip our primary care practices with the skills needed in order to deliver behavioral health integration in their own clinic. We have a large professional network across the state. It never ceases to amaze me on our calls that we have people from all across the state who are joining us. Policy and advocacy is a huge piece of what we do in advancing integration. This map represents where Patty and I are, where our headquarters is, and the clinics that we are working with up to this point. We continue to think about projects to include other clinics. We hope to reach across the entire state. Right now you can see where we are, one of the positive things that we have realized is once we start a project with a clinic, they'll talk to each other about the work that we're doing, and they'll say, hey, did you know this is what's going on? Or, hey, did you know there's a training on this? Or here's some resources. And so for me, it's been extremely positive to see that they're spreading the word, they're sharing the resources, and they're really incorporating the resources into their everyday practices. Arkansas is a rural state, though, and we know that we're going to need to be working innovatively to try to reach those rural areas. So what are the activities that we're doing? Well, we've been pretty busy since we became a nonprofit. I told Patty I left private practice and didn't realize how busy we would be, but we're extremely busy, and we feel very fortunate. We've written several HRSA grants, but we've had 2 grants that we've been awarded, one for opioid use disorder and the other for intervention, prevention, and postvention. And one of the reasons that we focused on these 2 areas is we hear from clinics that when they're doing a screening and someone presents and they have suicidal ideations, it can be really upsetting. And so how do we help them learn to manage a crisis internally within their primary care clinic, and just equip them with some skills so they feel confident in managing the patient until they do make a referral. And of course, opioid use. Arkansas is not immune to the opioid epidemic. And so we felt like that was really, really important for us to key in on that. One of the things that we're hearing, last week, we had the opportunity to go out and do our first site visits. Since COVID's been happening, everything that we've done with practices has been virtual, but we felt like people are starting to get vaccinated. There is a higher comfort level. And so last week, we actually went out across Arkansas, took a road trip, and we had the opportunity to interact with practices and hear from them firsthand on specifically what are some of their needs. We've heard a little bit about their thoughts about behavioral health integration, but I think that it was helpful to me to get to see the clinics when we're talking about workflow, to actually get to see how the clinics were set up, what the workflows looked like. Several clinics asked us to go over their suicide policies. And so we feel like we have this opportunity to really provide some hands-on training. One thing that's really important for us that we do is really this started before we actually became an organized nonprofit. About a year and a half ago, maybe a little longer, we started to invite speakers to come and talk to Arkansas about behavioral health integration. And so we've had a whole different variety of national speakers that have come and talked to us on specific topics, everything from what is integrated behavioral health, what does it look like in primary care practices, development, implementation, and sustainability. And Dr. Gibson will talk a little bit more about that. A recent development for ABHIN has been we've developed a pediatric work group. One of the things that we're hearing is with behavioral health integration, there's not a lot of access in the pediatric side of things. And so there was a huge interest. We are fortunate. We have a wonderful interprofessional team that meets together monthly, and that consists of child psychiatrists, pediatricians, psychologists, social workers, counselors, policymakers, administrators. And the purpose of that is really to talk about what are the pediatric needs and how do we adequately represent them, and how do we provide training. We were asked by the Arkansas Department of Health, the Office of Rural Health and Primary Care, to write the section for their 5-year needs assessment on behavioral health integration. And that leads us to the work we're doing. We continue to do this amazing work with the CPC Plus Stakeholders Group. We participate in the quarterly meetings, but what we have done is we've recently provided a 3-part behavioral health integration series. We just did this in March. And so we had a lot of wonderful feedback, and Dr. Gibson will highlight that. Here's our website, ABHIN website, www.abhinnetwork.org. Please check us out. You'll be able to see the great work we're doing in Arkansas. We have our webinars recorded. They are on there with PowerPoints. We have links to articles on behavioral health integration, updates on projects, and we're really excited. One of the things, just to highlight, we also make all of this information available to primary care practices in Arkansas so they can access all of this information. Thank you so much. And at this time, I'm going to hand it over to my partner and friend, Dr. Gibson.
Yes, it's been fun for us to get ready to do this presentation, because you get in the weeds of what you're doing day to day, but it's been fun to look back and put the timeline together and all of the things that have happened. And it really has been a transformation and progress of change, and really liked what Dr. Watkins in her blog on the Millbank website this summer talked about. It's been a decade of commitment to primary care transformation, but starting to yield positive results. And this data comes from the Arkansas Blue Cross Blue Shield data that was also published in issue brief in July. And you can see that the trend of return on investment is beginning to become positive after some initial expenses. So this is from the issue brief, and we've got the link there. You probably are all very familiar with it, but our partners at Blue Cross, Alicia Burkmeyer and Adam Whitlock, along with the UAMS, Dr. Brown, Dr. Tilford, published this. So it's really fun to see this data demonstrate the return on investment and the per member per quarter savings, and to just see how it stepped through so that there's still an average saving and return on investment, but how it becomes accumulating over time. And from my perspective, to notice that this has been done and been very successful without really significant effect from behavioral health integration that could happen. From our experience across the state, practices have not been able to implement behavioral health integration to the extent that would bring the savings and return on investment that has been shown in research outside of Arkansas. Some of the pieces of that, it's not that our practices haven't been trying, because they have, and we've definitely seen progress. Part of when you're looking at the big picture, bringing up this driver diagram, getting ready for this, I realized, I've never really looked at all the pieces of this driver diagram and how complex it is, but how accurate it is. And so it made me realize, if I haven't even looked at it, then the practices, the primary care doctors, the care coordinators, they're not really appreciating the details and the wisdom that is just in this diagram. And part of the wisdom in CPC and what's put together is bringing some of the evidence for all of these pieces, but specifically behavioral health integration. They've done a good job. And one of the places to start is the definition of BHI. People misunderstand and often think behavioral health integration means getting a mental health specialist and putting it in your clinic, and they continue doing what they've been doing. But behavioral health integration is transforming the way primary care healthcare is done. It's the primary care team and working with behavioral health practitioners. we've got to still overcome that separation and the barrier between primary care and the behavioral health providers. And it's not just doing the same old thing. It's a very systematic, cost-effective population approach, which is very different than specialty mental health. The CPC Plus implementation model did a great job of presenting to practices the two options, which are the two best evidence-based models for behavioral health integration. And that is the care management model, which is really the collaborative care management model that has been published. There's been more than 90 randomized controlled trials, and the Ames Center and University of Washington have this very well published. There's codes. And so that was one option. The other option is a primary care behaviorist model, or PCBH. This is a great job that CPC Plus put it out there, and most of the practices on their reports have said they are doing one of these models. The thing is that they're working hard to do it, but they are not doing the models as the evidence has been published. Specifically on the care management side, a lot of times they're saying that they're providing care management, but it is with their care coordinator that is providing chronic care management. It's not necessarily someone that's had behavioral health training. It's very rare to find a psychiatric consultant involved in this care management. In Arkansas, there is very few, and I'm sure less than 3 psychiatrists involved in practices, and some of that's been part of research studies that are being done. So practices have been doing some of this and working hard, but not doing it to the extent that it shows the evidence that that BHI does accomplish the purposes. The primary care behaviorist model, most practices have tried to hire someone and put them in their clinic, but the key is here when it says evidence-based behavioral treatment customized for primary care. This is definitely not the same thing that's being done in traditional mental health settings, and practices and behavioral health consultants are having to learn how to do that. So how do we stay motivated and continue to make the next steps? Because we've definitely made progress, but we need to continue to make progress if we're going to take this to further fruition of what could be accomplished, and not slide back. There is concern from the practices that when CPC Plus ends, that they're not going to get the same sort of support and coaching and training and support that they've had through the CPC Plus program. We've gotten a lot of information from the practices about their concerns and about what they have done and about what they want to do in our involvement with some of the CPC Plus training. So in October of 2018, we had an in-person training that we were involved in. In December, we had an online CPC Plus training for behavioral health and integration implementation. And in that training, we realized from the feedback from the practices, we needed to give them more intense information. And so we developed, along with our CPC Plus trainers, 3 weeks of training back to back. The one on development was kind of starting if programs don't have a program going and what things they need to look at. In the middle was the implementation pieces, how to build on what they've done, and then the sustainability piece. And the green comments are after the last meeting, that people were happy about it. There was good attendance, but there's still a need for more and more training and to understand how to really implement the model. This clinic feedback is from some of the clinics we work closely with in our grants, but also some of the clinics we've gotten to know through CPC Plus, that there's still themes of needing more training for the clinics, for the BHCs, but also there's billing and coding issues. How are we going to financially sustain this when we don't have the fees that come through the value-based programs? There's even in the weeds issues about HIPAA documentation, sharing of records, and then again, getting the PCPs to buy in as well as clinic staff. This was a very brief informal survey that these were the exact word comments that came from practices about still needing buy-in. We've done a lot of transformation around the primary care doctors. Teams have grown up around them, but we're still needing more training and engagement of the doctors and of the clinic administrators. They know these things are a great idea, but when it comes down to the weeds, it really is kind of like getting COVID vaccinations. Everyone's now understanding the science behind it. And nationally, we know it's a good idea. But when you start looking at how do we actually implement this day to day in a state, in a practice, it's challenging. There's still lack of understanding of the return on investment and what's the financial sustainability. So it's really great to see the research that our Blue Cross team has published. So what's our role? We see our role as kind of bringing in the global, the evidence, the national research, and then bringing it home to be relationships. So it's not just the University of Washington says this is a good thing. It is through relationships with Patty, with Kim, with Adam, with Alicia. It's really has to happen one-on-one and not just one time watching a great webinar, there's a lot of training out there, but it takes coaching and people have to be able to come back and say, we tried this, what help do we, what can we do now? So this is where we see ourselves is experienced, bringing in the national evidence, but then being able to help people, individuals, as well as clinics. And the other piece is advocacy and awareness. And the picture at the bottom is Kim and I with Dr. Kent Corso, our consultant on suicide assessment and training when we were down at the Capitol last week when he was in town. So we really do see ourselves as wanting to be involved in sustainable transformation and have several things we'd still like to develop in terms of expanding our website, creating a national conference, and training in the state. There's been a lot of good things happen. It's a little bit scary to think about how things are going to change as CPC Plus changes, and then the pandemic bringing in all new challenges with mental health. But there's definitely light and hope and light at the end of the tunnel, and it's exciting to see how far we've come with our partners and teams. So that's wanting to try to finish to give people time if they have comments, questions, discussion, and we appreciate the chance to be here.
Thank you so much, both Patty and Kim. This has really been wonderful. I love that rainbow. It's gorgeous. So I also wanted to just give our colleague Adam Whitlock a chance to make a comment. And Adam, I didn't have a prepared part of the presentation, but did you have anything you wanted to add to what Patty and Kim have shared with us?
Sure, thanks, Lisa. I just want to say thank you to Dr. Gibson and Kim. As we got started with the stakeholder group, they were some of the first people that we came to participate, and especially knowing Kim's geographic issues there at a 3-hour trip. It was a Friday afternoon meeting ending at 3 or 4 p.m. So it's a long trip home on a Friday afternoon, but she stuck with it, as obviously did Dr. Gibson. And so just thankful for their input. If you're thinking about, why was this successful or how is it successful? I think it goes back to the stakeholders that we had in the room. As a payer, we can only affect certain things in the healthcare system that are specific to a payer. But Dr. Gibson and Kim were in the field doing the work, and so they bring their unique perspective and experience. We had hospital association there from their experience. We had patients in the stakeholder group, and all of us combined, along with other payers and other organizations, came up with behavioral health as an important need to address in the state. And so thus formed the Arkansas Behavioral Health Integration Network. And Dr. Gibson and Kim have taken that and just run with it and are doing so much. As a payer, as you guys know, we can provide all sorts of data. We can slice it and dice it and filter it however we want, but clinics don't always know what to do with that data to make a meaningful change. And this is where ABIN comes in and is able to bridge that gap for these Arkansas clinics. And so we're just in the beginning stages. They're being successful and looking forward to more success in the coming years.
Great, thank you, Adam. So we have a couple of questions that came in on the chat. I guess we'll go to those first, and then if others have questions, either type them in or feel free to just speak up. So from our colleague Deb Hurwitz, who we'll be hearing from shortly, she was curious how you got a TA designation, both approved and then available through HRSA.
Sure. So really with that process, what we did is to become a technical assistance center, the first step for us was to become a nonprofit. And so we developed a board. We started meeting regularly with our board. We probably did that for about 6 months or so before we became or received our 501c3 status in the mail. And then we started to apply for HRSA grants, and we wrote in the functionality of providing technical assistance on these projects to primary care practices. And so we were grateful that we were approved for those. And since that time, we've been providing those services.
That's great, thank you. And is it, and you said it's for all primary care, it's not just FQHCs that you have to focus on necessarily?
Correct. What we did is we invited practices to participate with us, and it is, a process. They have to make the time commitment, that they're willing to attend monthly consortium meetings, that they're willing to participate in the pieces of the project, willing to at least explore and try implementing some of the different ideas and functionalities, but they've been fantastic. And so we're 6 months in on both of these grants, and we're at the stage where we're starting to expand our consortium. And so at that point, we'll be able to invite other primary care practices to participate and join us.
Thank you so much. That's terrific.
Yeah,
Good for you.
thank you.
Thank you for your question.
So I have another question in the chat from Dr. Shank at the Health Collaborative in the Ohio-Kentucky regions, and I'm specifically asking, can you speak more to the two different models for integration? So there was care management versus a specialist model. How do they operate differently in the practices, and do you find that the rural practices have fewer options, just sort of as a practical question? And then a third part of the question, do they operate in tangent sometimes where you have both models in operation?
Yeah, that's a great question, and it is debated by different people in different parts of the field. But the short answer is they are very different. They can fit hand in glove together. They can definitely be complementary, and practices can do both. Sometimes you need a different team, sometimes the same. Let's say you're using an LCSW as your behaviorist. That LCSW can also function as the care manager as part of the collaborative care management role. But sometimes you have different team members. At the VA and in the military, they call it having a blended model, where you actually have both models. You have a psychiatrist involved, and then behaviorists who are located in the clinics, and they may be psychologists, social workers, therapists. And then the care managers in the VA, they tend to be remote, either by telephone or televideo, but the care managers can be on site. And you're right, with rural practices, it can be a challenge. On the one hand, you would say, well, it's pretty easy now. We can do telehealth. And the thing about mental health and telehealth, it definitely can, most mental health treatment and therapy can be done via telehealth, especially televideo. Because if we can see each other, then we can get a sense, and it has been shown to be safe and effective. But one of the things, we keep talking about relationships, One of the issues is that when patients are referred to mental health, 75% of them never go to their first appointment. And it's because of stigma and they don't have a relationship with that mental health person. So that's one of the reasons why behavioral health integration works. It's having a team member who is in the clinic with the primary care doc. So we are still trying to work to, in rural clinics, to ideally would be to have that behaviorist or someone in the clinic right alongside the primary care team. But we're hoping that with time, we could also have more of a virtual behavioral health team that the primary care team can say here and do a warm handoff with the behaviorist virtually, but the patient still being in the primary care clinic. And there have been some behavioral health integration programs that are being done virtually. So I'm happy to, that's a long answer to actually a long question. We could probably talk an hour about, and I'm happy to talk more if anybody has any questions about it. But it does get into the nuances that if whatever you're trying to accomplish, if you're trying to accomplish saving money, increase primary care provider satisfaction, increase patient satisfaction, a population health outcome, then you need to not just go into a practice and do what feels right, but to follow the evidence-based models. And that's where practices are struggling. If you don't have a BHC that has training, they don't understand the model. And then the practices don't understand the model because they want to say, here, you're a mental health person here. Let you go ahead and take this patient, as opposed to let's work as a team and take care of this patient as a team, or let's take care of this population of patients as a team.
Very helpful. Thank you. I appreciate the long answer to my long question. And I may take you up on that hour-long discussion. So I'll see.
Definitely. Feel free to give me a call or email.
Any other questions for our colleagues? I have a few I would be happy to ask, but I want to make sure others have a chance. So I want to ask some questions around some of the topics of our day. Certainly we are all still living through the coronavirus and COVID pandemic. And you did, in your answer to Dr. Shang's question around telemedicine and the, frankly, the sort of elevation of that in the sort of appropriately, because it was such an important tool when we were really unable to have people see anybody in person, even family members. And so just your impression about how smoothly you feel that transition has gone, because there's a whole learning curve side to it. And then there's also just the what you see as the sustainability opportunities for this, and what kind of balance you would. I'm sort of asking you to go on a limb a little bit, but what you feel would be the appropriate balance, because I think everyone is. These are payers mostly on the line who are thinking about how to provide support for primary care practices. Mm-hmm. And then the other piece that it may be part of this is just the equity lens that I think we are all appropriately now looking through, which I think is not new, but certainly increasingly relevant to all of our work, and just sort of your views of that.
Mm-hmm. One of the things, Arkansas is a whole diverse population, and we've already seen some of the people who are trying to do school remotely, that they don't have good internet access. I mean, the state is trying to improve the access to internet. So if you don't have good internet access, you really are, that's going to just prevent you from doing telehealth services. We're hoping that by having the patients in primary care practices, that might help with that. But then the primary care practices have to understand it's worth giving up a room that they couldn't bill for patients to let the patient have a mental health visit. So I think the transition has been good in terms of a lot of evidence is there. You can do mental health treatment via telehealth, but, and we're learning all the details. But I think one of the things for people to remember is by all of these companies that are growing up, there's all different names of private companies that are providing telehealth, mental health telehealth services, and they're all over, and the providers are different places. They're not an Arkansas therapist or an Arkansas psychiatrist, but it's the patient is in Arkansas, but these services are being provided by providers outside the state, the doc on demand type of thing. I think that there's still going to be a real lack of engagement of patients with telehealth clinicians who are not, that they don't have a connection with. That's one of the issues why patients don't want to go to a specialty mental health, because they don't have a connection with them. The other thing that they often complain about is they went to see a therapist or a psychiatrist, but then they left, and then they have to change again. And so I think we need to be careful of thinking we can't build a system that is a national doc on demand, pulling doctors and providers from different places and thinking that's going to provide all the services that our patients need. They still want their local staff, their local doctors, their local providers, and especially when they're talking about mental health issues, I think it's not going to be as big of an answer as we hope it will be. We're still going to need some local connections to make that work.
Absolutely. I was going to add that telehealth is such an important piece. When we first started our behavioral health work group in 2018, that was a question that we had. Could we add telehealth services as a way to potentially treat more patients with behavioral health integration and or just in general, especially because we are such a rural state? We didn't know that in 2019, when the pandemic hit, we would have an opportunity to really test out and experiment in how this would work. One of the things that we are hearing from practices, especially some of the rural practices that we visited, was that patients are really liking telehealth visits. They have quickly made the change. Most people have a smartphone today, and so sometimes they're having their visits on their smartphones. Sometimes patients are too comfortable, and they haven't gotten out of bed yet in the morning, and they're still having their visit. And so this is some of the feedback that we've been hearing about practices. I definitely think that now that we have taken off the rose-colored glasses, we can see telehealth is going to be such a critical piece of what we do. It's going to be an additional, in my opinion, an additional tool to provide important care to patients, especially in rural areas.
Thank you. That's great. Well, we are just about at the top of the hour. There's one quick question that came in also from Dr. Shank, and saying that many of the payers themselves have their own care managers that work for their organization. And is there any experience that you have had pulling them directly into the BHI implementation? Or if it's payer supported, then that's another question.
We are aware that there are payer care managers, and I think just nationally hearing about the payer care managers can definitely be involved in improving behavioral health issues and concerns. And but it's still bringing everybody to the team. I think they can be part of the team. It'll be important that the payers who have care managers also recognize that their care managers still may need some specific training around how to do good care management related to mental and behavioral health issues. We have such a split in all of our medical training that we go in and we're either mental health or not mental health. And so even some great care managers, they often are avoiding the mental health or behavioral health issues and not realizing what could be done. So providing them more training will be important. But I think we haven't fully recognized bringing in the payer care managers with the clinic care managers as well. We could do a lot more with that.
Thank
I'll
you.
just quickly add from
Yeah.
a Blue Cross standpoint, we're right now in the process of laying groundwork with our primary care first practices for collaboration between clinic care managers and Blue Cross care managers, specifically around behavioral health. So we're getting started.
Great. Thank you. It's exciting. We'll look forward to hearing more about that. Well, once again, I want to have big thanks, big round of virtual applause for Dr. Gibson, for Kim Schuler and Adam Whitlock.